Hello and welcome to our Nursing Times bite-sized learning video series on heart failure. Over the course of 5 educational videos, we will be covering heart failure pathophysiology, heart failure causes, diagnosis, management and also related end-of-life care. Each video is presented by a nurse who is an expert in the field of heart failure. We hope you find this series an informative and useful tool to both further your knowledge, raise awareness and ultimately improve your care of heart failure patients.
Hi everyone, my name is Yvonne Millerick and I am a heart failure palliative care nurse consultant lecturer from Glasgow Caledonian University and Glasgow Royal Infirmary in Scotland. This heart failure palliative care approach is encouraged across our heart failure communities to promote early patient identification, evolving comprehensive assessment, anticipatory care planning and meaningful conversation that places person-centred values at the very heart of service delivery. This anonymous quote has a particular relevance to the heart failure palliative care experience for patients and families. I say this because the wider literature asserts that palliative care and meaningful conversations in heart failure is often left too late. And if we think about the heart failure specialist role, we should remind ourselves that they are not specialist palliative care nurses. However, we have developed generalist working knowledge, caring for people from diagnosis to end of life. So without a doubt, evidence-based treatments are responsible for improving the 5-year survival rate of patients with heart failure, and yet advancing heart failure remains the leading cause of hospitalisation in 65 years and over. It accounts for 2% of the NHS budget, with 70% of those costs driven by hospital admissions. It is the final common pathway for almost all cardiovascular disease, and it is associated with significant mortality and morbidity. So the European vision is that generalist palliative care principles should be seamlessly integrated with unusual heart failure disease and device services. The timing of integration should be based on patient need and not prognosis, and should be integrated in such a way that people feel informed and enabled to be active partners in their decision-making process throughout. So what are the barriers that inhibit seamless integration of heart failure palliative care into practice? Well, one such barrier is a poor understanding of what palliative care means and what it has to offer. The wider literature asserts that this originates from the perception that palliative care is synonymous with end of life and patients who are considered to be imminently dying. If, however, we look at the World Health Organization definition, it clearly states that it's an approach that improves the quality of life of patients and their families facing life-threatening illness. It encourages early identification and impeccable assessment and aims to help patients live as actively as possible. It adopts a team approach and it is applicable early in the course of the illness in conjunction with other therapies that are intended to prolong life. Nowhere in this statement does it say that it is exclusive to end of life and persons who are imminently dying. Uncertainty often leaves heart failure professionals feeling a real lack of confidence about when is the right time. The reality is that uncertainty will remain, and if we look closely at both of these trajectories, the one certainty that we can observe is the subtle irreversible decline, where the patient never quite gets back to the health and well-being status that they previously experienced. Without a doubt, communication underpins all aspects of heart failure palliative care. A paper by Professor Fitzsimmons ranked communication as number 1 of 3 themes which contributed to suboptimal care experience. The literature highlights that professionals perceive these conversations to be difficult, often citing time constraints, lack of confidence as reasons for not having them. If we consider something to be difficult, however, we will avoid having them, and we should consider these conversations as naturally occurring in response to the inevitable changes that are already happening to patients and families. In the absence of meaningful what matters anticipatory care planning conversations, patients and families experience adverse clinical outcomes, associated with terminal hospital admissions, significant burden of unmet needs, and the opportunity to disclose their evolving care preferences. Studies highlight that patients and families with heart failure not only hope to experience a level of wellness and stability, but also want to be informed about treatment options, including a strong preference for information to be disclosed about the possibilities of deterioration and inevitable death. Their need for truth-telling should always be balanced with hope regarding quality of life, symptom management, and control of decisions regarding care, preferences throughout their illness, and towards the end of life. The Pumpin' Marvellous Guide has been designed to raise awareness, change existing perceptions, and encourage the inclusion of palliative care to the overall management of heart failure. It has been developed in partnership with patient experts and heart failure specialist nurses from across the UK. The Cardiac Palliative Care Guidance resource consists of core components of care and suggested initiation and responses to key questions associated with understanding diagnosis, expectations for now and in the future, advancing disease and its associated impacts, anticipatory care planning including care preferences, DNA CPR and device deactivation, and includes an approach to symptom assessment. The core components that the heart failure nurse is encouraged to consider include early identification and prioritising of high-risk patients to one of three groups, a comprehensive assessment to determine cardiological and comorbidity status alongside a person-centred assessment, a what matters approach to anticipatory care planning to encourage meaningful conversation about what a person would like, what they don't like, and how best to care for them now and during periods of change. Cohesive working is encouraged to acknowledge the unique contribution of the wider professional team and to manage expectations and enable the provision of high-quality care and support. So how does early identification change existing practice? Well, the current model focuses on a reactive model of care where the patient experiences a crisis, is admitted to hospital, and will sadly either die or be discharged back home with minimal information to support goals of care and care preferences. If we're able to focus on early identification, we can adopt a proactive, integrated model of care that reflects the patient's realistic choices throughout their heart failure trajectory. So triaging patients to one of three groups helps to identify those that are most likely to be at highest risk of deterioration. And these patients are most likely to be NYHA classification 3 or 4, despite being on optimal tolerated evidence-based therapies. They will be vulnerable to hospital admission and/or frequent review by the specialist nurse. They will require frequent adjustment of their diuretic and adjunct therapy to minimise symptoms, and they will have coexisting disease which is further affecting optimisation of their cardiac care. They will also be experiencing change with reduced function and increased frailty, and you may not be surprised if you were to ask yourself the surprise question if they were to die in the next 12 months. The What Matters conversation plan invites patients to disclose their interests, values and preferences as real people and not just as recipients of care. Physical, mental and well-being changes are already happening to them. Therefore, inviting them to disclose what matters, who matters, why and when it matters will enable them to be informed and become active partners in the decision-making now and in preparation of them becoming less well and less able in the future. The comprehensive assessment includes appraisal of patient and families' understanding and management of their expectations for now and going forward, confirmation of the cardiological and comorbidity status, goals of care, carer assessment, and assessing the needs now and in preparation of change are vital. We can evidence change using validated assessment tools. Adopting a what, why, who and when matters approach to anticipatory care planning encourages person-centred meaningful conversation about what a person would like, what they don't like and how best to care for them during periods of change associated with stability and/or deteriorating health, personal care and/or personal circumstances. This timely approach supports the creation of individualised, evolving care plans that are created in partnership with the patient, carer and key professionals involved in the delivery of care. So how conversation ready are we? We plan and prepare for so much change in our life, such as marriage, birth, moving house, etc. And yet we very rarely invest the same time to thinking ahead and making plans for the physical, mental and general well-being changes that will inevitably happen to each and every one of us. Please remember that talking about inevitable change now does not make it happen any sooner. Furthermore, the uncertain trajectory should only reinforce the importance of engaging in meaningful and evolving conversations now and throughout the heart failure trajectory. So the impact of cardiac palliative care components and person-centred meaningful conversations into everyday clinical practice does provide an ideal approach for the modern healthcare system by promoting maximum shared knowledge, understanding and minimal uncertainty. And by doing so, patients and families are able to live well, experience a dignified death and leave behind a positive legacy. Changing our perception of what palliative care is and what it has to offer provides heart failure professionals with an opportunity to engage in person-centred conversations and the integration of core components throughout the heart failure trajectory. In doing so, we can support patients and carers to have realistic expectations and experience true person-centred care at the right time, in the right place, and at a time of real need. From a heart failure professional perspective, there is simply nothing more rewarding.